Ladies and gentlemen, on behalf of the Executive Board, we would like to welcome you to this year's dance lecture. It's great to see that so many of you have come. Again, I was told each year we have such a full audience. My name is Rianne Letschert and I'm the Rector Magnificus of this university for those of you that see me for the first time. The Tans lecture is organized every year to honor Dr. Sheng Tans, one of the founders and the first president of our university. The aim of this lecture is not only to keep his name alive, but also to do justice to his convictions and his strength of character. And I've read his biography this weekend, and that's really recommended literature, I must say. We can think of his fighting spirit, social engagement, perseverance, positive attitude, and commitment to following his own conscience. The Tans speakers for this lecture work in different areas of academia, politics, or culture, and typically represent somewhat contrary or unconventional voices, so you know what we expect from you. I am honored and proud to be able to introduce to you tonight's speaker, who certainly fits well with this tradition. This evening's theme, and the theme of her latest book, revolves around a phenomenon that has intrigued me for many years: the power of the mind. I have personally seen how people in post-conflict areas in Africa manage to turn mental strength into physical strength. At this very university, researchers have shown that an optimistic attitude can guard against physical pain. I still recall research from Harvard Medical School a few years ago demonstrating that people with irritable bowel syndrome felt much better after taking pills they knew to be placebos. And that was by no means the only study to draw attention to the power of placebos, and thus our minds. Jo Marchant's book, Cure, A Journey into the Science of Mind over Body, focuses on how our brains help to heal our physical ailments. She is an outstanding science journalist whose book brings together scientists from diverse fields and reveals evidence that our thoughts, emotions, and beliefs can have very real benefits for our health, from easing symptoms and influencing immune responses to reducing our risk of getting ill in the first place. The New York Post referred to her book as a well-researched page-turner that raises questions about the role of culture, environment, and neurochemistry in our responses to treatment, and may very well lead to widespread changes in the ways we practice medicine, unquote. And according to the Washington Post, Cure is a rewarding read that seeks to separate the wishful and emotion-driven from the scientifically tested. Wonderful reviews you have received. And that, ladies and gentlemen, is of course exactly what a good science journalist should do. In addition to translating scientific findings for a wide audience, science journalists feed the public debate and keep a close eye on scientific developments. Her particular strength is that she combines great writing with her own solid scientific background. With a PhD in genetics and medical microbiology and an MSc in science communication, she is ideally placed to write blogs, articles, and books that lift the lid on the scientific world for all of us. We are very honored that you are here with us tonight to deliver the annual Tans lecture and to give us a glimpse of your world. I wish you all an enjoyable, educational, and inspiring evening with Jo Marchant. Thank you very much.
Hi, thank you so much for that wonderful introduction, and thank you so much for inviting me to Maastricht. I'm really honoured and excited to be here. So I'm going to talk to you about the influence of the mind on the body. To put it another way, I guess you could ask, can our thoughts heal us? And I don't know if any of you have a bit of an emotional reaction to that question. It's a question that both fascinates us and divides us. People have very differing answers to that question. On the one hand, we have claims that the mind can cure pretty much anything if we think positively enough, often coming from alternative therapists and healers. These are just a few books that I found doing a search on Amazon. We've got How Your Mind Can Heal Your Body, Anything Can Be Healed, How to Heal Yourself Instantly from Disease, Depression and Fear, How to Heal the Sick as a Beginner. I quite like the look of that one. Even Mind Over Medicine. This one claims to be based on cold, hard science. But I want to read you a typical quote from the author of this book. She says, "We hold within us self-healing superpowers that are stronger than any chemotherapy and more effective than any surgery." So these are really strong claims that are being made on this side of the debate. And then on the other side, we have the skeptics. They're often from the fields of conventional science and medicine, often bloggers rather than book authors. These are just a few quotes from interviews that I've done with scientists and also comment pieces that they've written. And these skeptics would argue that any idea of healing thoughts is deluded, dangerous, quackery. The idea that our thoughts could heal us is rubbish, tooth fairy science, oppressive and morally offensive. One researcher said, "Why would actively doing nothing have any active physiologic effect? It doesn't and it shouldn't." So that just gives you a sense of kind of the emotions, if you like, the strong feelings in this debate. And it seems to me that both of these positions come from the idea of the mind as mysterious, magical, not real in some sense, something that doesn't really obey normal physical rules and can't be studied. And I think that leads the believers to kind of think that therefore the mind can do anything, and it leads the skeptics to think, well, the mind couldn't possibly do anything. And I'm a science journalist, as you heard in the introduction. I have a background in science. But neither of those positions really made sense to me. So in writing this book, I wanted to take a look at what the research on this really says. Can the mind influence our health? If so, what can it do? What can it not do? How does it work? And so that's what I'm going to talk about today. I'm going to look first of all at symptoms, things like pain, nausea, fatigue, how ill or well we feel. And then I'm going to talk about the way that our minds affect our physiology, the basic physical processes of disease. Can our thoughts, for example, ever make the difference between life and death? So we're going to start with this lady. This is Bonnie Anderson. She's here with her partner, Don. She lives in Minnesota. She loves playing golf. And in 2005, she slipped over on wet kitchen tiles and fractured her spine. And she told me that after this, she was in a lot of pain. She wasn't able to stand up to do the dishes. She wasn't able to play the golf that she loves. She was in too much pain to sleep. So she took part in a trial of a promising new surgical procedure called Vertebroplasty. And this was becoming increasingly popular a few years ago. Essentially, surgeons inject medical-grade cement into the fractured bone to strengthen it. And it was having seemingly wonderful results. Patients were saying that their pain was gone within a few hours. Within a few days, they were back to all of their normal routines of daily life. And this was true for Bonnie as well. She told me that it was wonderful. She said the pain was gone. I was able to go back to my golfing and everything that I wanted to do. Except that what she didn't know at the time was that the surgery she received was fake. The surgeons acted out the whole procedure, and she never received that injection of cement. And she wasn't alone. There were 131 patients in that trial. Overall, their pain and disability scores were almost halved, but there was no difference between the real surgery and the fake surgery. So this is a classic example of a well-known phenomenon called the placebo effect. This is where Often when people receive what they believe to be an effective medical treatment, they feel better, even if it turns out that that treatment was fake, there was nothing in it. And we see placebo effects over many different kinds of conditions, many different kinds of treatments. We think of placebo pills, but we also see placebo effects for injections, surgery. It's the reason why we test new drugs against placebo, so that we can be sure that any improvements seen are down to the biochemical effect of that drug and not to this more general placebo effect. But when it comes to the placebo effect itself, it's often seen as little more than an illusion. The argument goes that if somebody feels better after receiving a fake treatment, then maybe they would have recovered anyway. A lot of people do just get better with time. Maybe they just think that they feel better, or maybe they're just saying that they feel better, even if nothing has actually changed. Skeptics have described the placebo effect as a myth, a failure. My favorite, I don't know if this really translates, but the placebo effect was described as the beer goggles of medicine, this idea that it's pretty much wishful thinking. And all of these things are valid explanations for why people might report improvements after receiving a placebo. But there's now decades worth of research that suggests that there is also something else that's going on. So to talk about that, I want to take you back to 1978 and a crucial experiment that placebo researchers describe as the moment that the biology of placebo was born. A neuroscientist called John Levine at the University of California, San Francisco, wondered whether, rather than being all in the mind, whether the placebo effect could be working through a biological mechanism. Scientists at the time had recently discovered naturally occurring chemicals in the brain called endorphins. These are these sort of natural feel-good chemicals that you probably heard of. They ease pain by blocking pain-related signals in the brain. And opioid drugs, things like morphine, heroin, they work by mimicking endorphins. They bind to the same receptors as endorphins in the brain. And Levine wondered whether placebos might somehow be triggering the same pathway. So he did an experiment on patients recovering from surgery in hospital. He gave them an intravenous infusion of saline, salt water, that he told them might be the powerful painkiller morphine. And after they received this infusion, the patients reported that their pain had significantly reduced, so a classic placebo effect. But what he did next was interesting. He gave them a hidden infusion, so they didn't know that they were getting it, of a drug called naloxone. Naloxone blocks the activity of drugs like morphine by blocking those endorphin receptors. And after this infusion of naloxone, even though that the patients knew nothing about it, they reported that their pain had gone back up. So Levine had shown that when the patient's pain reduced after they received that placebo, they hadn't imagined that change. It could actually be blocked biochemically with a drug. So this suggested that it was working through the same biochemical pathway as drugs like morphine. Receiving the placebo had somehow triggered the release of endorphins in the brain. And there's been a lot of work since then confirming that mechanism of action, and also showing that when people respond to placebo painkillers, there's reduced pain-related activity in the brain and even in the spinal cord. One of the top placebo researchers in the world today is this guy, Fabrizio Benedetti. He's a neuroscientist at the University of Turin. And he was inspired to start studying placebos after that 1978 study. And he has shown that we get these biological placebo effects, not just when we take placebos, but when we take real drugs as well. So, for example, it varies, but trials suggest that when we take a painkiller, between 1/3 and 2/3 of the pain relief that you feel is not down to the direct biochemical action of that drug. It's down to your psychological response to the drug, to the placebo effect. He's shown that very commonly taken drugs, things like Prozac and Valium, are not effective at all unless you know that you're taking them. He's also shown that there isn't just one placebo effect, there are many. So I've explained about one mechanism, which is the release of endorphins in the brain. But there are lots of others. One well-studied one is in Parkinson's disease. So in this condition, patients suffer from problems with movement because of a lack of dopamine in the brain. Benedetti and other neuroscientists have shown that when those patients respond to placebo, there's a flood of dopamine in the brain, just as when they take their real drug, and in some situations as large as when they take their real drug. A third example that Benedetti is studying is altitude sickness. He's built this lab specifically to study it. It's 3,500 meters above sea level in the Alps on the border between Italy and Switzerland. In fact, the border runs right through the middle of his lab. This is just a view out of the window, just so you can see how just how high up and remote this lab is. You need to take 3 separate cable cars to get there. And this guy is David, one of Benedetti's volunteers. He's driven from sea level Turin that morning to try to maximize the effect of the altitude sickness. And he's working out on the stepper. He's breathing oxygen, or he thinks that he is. This canister is actually empty, so he's breathing placebo or fake oxygen. Benedetti has been comparing groups of volunteers who get this placebo oxygen and those who don't. So the only difference between them is that belief that they're breathing that supplementary oxygen. And he's shown that the placebo group perform much better at altitude, and they have reduced symptoms of altitude sickness. And again, this is caused by a physical mechanism. The level of oxygen in their blood doesn't change, not surprisingly, when breathing fake oxygen, but they have a drop in the levels of chemicals called prostaglandins. These are produced by the body in response to low oxygen conditions, and they're responsible for many of the symptoms of altitude sickness. So in all of these examples and others, researchers like Benedetti say that we have, in effect, an inner pharmacy, molecules that are produced by the brain, things like endorphins, dopamine, prostaglandins, that regulate our physiology in different environmental conditions. They can create or ease symptoms. Many of the drugs that we take work because they mimic these natural chemicals, but through taking placebos, we can sometimes influence those pathways directly. So, what triggers placebo effects? This has been quite hard to pin down in trials. The proportion of people who respond to placebo varies from 0 to 100%, depending on the circumstances. The exact same placebo can have a positive, negative, or neutral effect, depending on what you're told about it. And at first sight, this doesn't seem to make any sense. It kind of adds to that sense that placebo effects somehow kind of a bit suspect or not real. There's nothing in a placebo, so how could one placebo have a different effect to another? How could nothing be different to nothing? But that really comes from looking at placebos in the wrong way. By definition, a placebo can't do anything. It's inert. There's nothing in it. What triggers the placebo effect is your psychological response to that placebo, what receiving that medicine means to you. And of course, that can differ between individuals and in different circumstances. One of the main psychological factors that seems to be feeding into this is expectation. So how do you expect your condition to change or improve? And that in turn depends on a lot of other different things. So what you're told about a treatment, whether that treatment has helped you before, whether you're an optimistic person in general. There are cultural factors as well. Generally in studies, red or pink pills seem to be particularly good at triggering placebo responses for pain, whereas blue pills are more calming. They're better for treating anxiety or problems with sleep, except among Italian men. I don't know if you can guess why. The researchers think it's because blue is the colour of their national football team. So for them, blue is not calming, it's exciting. And so that's just to make the point that it's nothing inherent in the placebo itself. It's all about what that placebo means to you. In terms of what placebos work for, there's little evidence that your simple belief in a treatment is going to have a significant effect on underlying physical processes of disease. It's not going to affect hormone levels or immune responses, for example. There is another class of responses where inert treatments can do that, and I'm going to talk about that a bit later. But in general, your belief in a treatment is not going to affect your immune system. It's not going to change cholesterol levels or replace insulin in a patient with diabetes. It's not going to banish a tumor or fight off an infection. But where placebos can be very effective is in easing symptoms that we are consciously aware of. So that's things like pain, from arthritis to burns, nausea, fatigue, itching, wheezing. Placebo responses are strong in psychological disorders, from anxiety to addiction, and they can also affect objective physical changes, things like rashes, swellings, gut problems. So it's a very large range of conditions and symptoms that we would usually medicate with drugs. I want to talk in a second about how we might make use of some of these processes in medicine. But first, I want to talk about a question that for me was always one of the most interesting questions about placebos, which is, why do placebo responses happen? It sort of seems too good to be true. Like, why would expecting a certain change to happen make that change happen in your body? And to answer that, I think it's important to think about why we experience symptoms in the first place. Things like nausea, pain, fatigue, they're not there just so that we feel miserable. They have evolved as warning signs. They have a survival value. For us to be consciously aware of these things, it warns us that there is a threat and encourages us to change our behavior, to remove ourselves from that threat. So fatigue, for example, is a warning not to overexert ourselves when it might be dangerous to do so, whether that's because we're at the top of a mountain and oxygen levels are low, or whether we're ill with the flu. Pain is a fairly obvious one. If you break your ankle, it's a warning not to keep walking or running on that ankle. Nausea is a warning, for example, not to continue eating food that's poisoned or bad. And that what I think is really interesting is that the scientific understanding that's emerging about these symptoms from placebo research, but a lot of other fields of research as well, is that these symptoms, our awareness of these symptoms doesn't just arise blindly and inevitably from the physical state of your body. These symptoms have costs as well as benefits, and the brain is constantly calculating the appropriate level of those symptoms for you to be aware of. And it's doing that depending on how severe it assesses a particular threat to be. And obviously the physical state of your body is very important in that, things like injury or infection. But that's not the whole story. Also, cues from the external environment, things like oxygen levels or temperature feed into it. You feel more fatigued when it's hot, for example. And also psychological cues, your assessment of a threat, either conscious or unconscious, also triggers biological changes in the brain that push your symptoms up and down. If you're very worried about a particular threat, that can trigger changes that amplify the relevant symptoms. Benedetti in his lab up in the Alps did quite an interesting study on this. So we had more than 100 students who came up to visit the lab, and he found that among those who knew that headaches are a symptom of high altitude, that there's a risk of headaches at that altitude, they suffered more headaches and more severe headaches than the ones who didn't know that that was a risk. This is like a reverse placebo effect, if you like. It's called the nocebo effect, where you can experience a symptom because you think it's going to happen. And he showed that in that group, the ones who knew that headaches were a risk and therefore suffered more headaches, that was caused because their bodies produced higher levels of prostaglandins than normal. So that the body was being extra cautious, if you like. They were worried about the risk of headaches, and therefore the brain was taking extra safety measures, producing more prostaglandins. When he gave them placebo aspirin, it brought the prostaglandin levels back down, and it brought the headaches back down as well. So that's a kind of example of where being worried about symptoms can amplify them, but then if that concern is taken away, if we feel safe, cared for, we receive a treatment that we think is effective, that can bring the symptoms back down. So can we use these processes at all to help patients? Can we sort of purposely try to trigger these changes to ease symptoms? In general, it's seen as unethical to use placebos in medicine. The traditional understanding is that a placebo will only work if you think it's an effective treatment. So to prescribe one, your doctor would have to lie to you, and that is not seen as ethical. But in the last few years, there have been studies suggesting that honest placebos can work. So as Rihanna mentioned, in conditions such as irritable bowel syndrome, depression, migraine, back pain, ADHD. This is Linda Bonanno. I visited her in her home in Methuen, Massachusetts, and she has suffered from irritable bowel syndrome for more than 20 years. and she took part in a study at Harvard, and she was really excited about receiving the latest experimental treatment, and they said to her, well, we would like you to take these sugar pills. We think they will help you. And she told me that she was really not impressed by this. She went home, she took them anyway, she said she was desperate, she was going to do whatever the doctor said, and within 3 days, her symptoms disappeared. She said she felt wonderful for the 3 weeks of the study until the placebos ran out, and then her symptoms returned. She was probably one of the more extreme cases in that study. There were around 80 patients in that study. Not everybody responded as dramatically as she did, but overall, the ones who took the placebos and knew that they were placebos did significantly better than the ones who didn't. And since then, there have been several more studies showing similar results. I wanted to show you the results of this one in migraine headaches, looking at 459 attacks in 66 patients, and it shows you quite a nice dose-response curve. They kind of had a whole load of different groups. So for the patients who received no treatment, 2.5 hours after the starting point, their pain was 15% worse. If they took a placebo and knew it was a placebo, their pain was 15% better, so like a 30% improvement. But you can see that if the placebo was labeled as a drug, it was more effective. Oh, apparently if I touch the screen, it changes the slide. Or if they took the drug labeled as placebo, there was actually no significant difference between those two. And then if you took the drug labeled as a drug, then that was the most effective. So you can see that there's something about just taking a pill that helped. Something about the labeling that's helping regardless of what drug you're taking. And then if you have everything combined, if you have the drug and the labeling combined, then that gives you the strongest effect. In this study, it was interesting because for the same labeling, placebo was about 60% as effective as the drug. So you could say that 60% of the pain relief was coming from the labeling, 40% of the pain relief was coming from the drug. But there are other cases, so other trials have been done in more chronic conditions, so like the irritable bowel syndrome, but there was another one published very recently in chronic low back pain, where some of those patients had tried lots of different drugs and not responded to any of them, and then they actually had very significant responses to the honest placebo. And there's a big debate going on in the field right now about why that is. Whether it's the fact that it's just something different, people have had bad experiences with drugs in the past, whether it's something that's, because those patients were also given information similar to what I'm giving to you now about why placebos might help. So some researchers think it might be something to do with empowering those patients and changing their relationship to their pain. So should we all be taking placebos? You can buy them online if you want to. This is my kitchen cupboard at home, and there are some placebos that I bought on the internet. My argument would be that if we have effective medical treatment for a particular condition, then there isn't much point in switching to placebo, because if you take the drug, then you get the active effect of the drug and you get the placebo effect, so best of both worlds. But there are several situations where drugs actually aren't very effective and where there are significant downsides to taking drugs, things like side effects and addiction. And this is conditions like chronic pain, irritable bowel syndrome, mild to moderate depression. And in these cases, some researchers are now starting to argue that we might actually offer honest placebos to some patients if they want to try them before progressing, if necessary, to active drugs. Another way, some researchers are arguing of harnessing placebo responses more ethically is in alternative treatments. So there are several alternative treatments, things like Reiki, homeopathy, acupuncture, that from a scientific point of view don't have any active ingredient. In trials, they generally perform no better than placebo, and that the conventional conclusion would then be, well, these treatments are worthless, there's nothing there for patients, let's just throw them out. But that isn't necessarily the case. There's one trial that was carried out in Germany on more than 1,000 patients with chronic low back pain, and in that trial, there was no difference between real acupuncture and fake or placebo acupuncture. So this is done with quite clever retractable needles that look as if they're going into your skin, but actually they're not, and they're also put in the wrong places. So no difference between the two. This is often what you see in trials of acupuncture. But what was different about this trial was that they had a third group, and that group received conventional treatment, including painkillers. That group did barely half as well as either of the groups that got the acupuncture, whether it was real or fake. So that's telling you that sometimes alternative treatments, even if they're working through placebo effects, can trigger such large placebo effects that they're actually better than the best that conventional medicine has to offer. And there are several groups of researchers now trying to tease out, well, why is that? Trying to look at, well, what are the real active ingredients of these alternative therapies? And they're finding out that the human aspects of care, the bedside manner, if you like, is very important. One of the main researchers looking at this is Ted Kapczyk at Harvard. He's the one that did that irritable bowel syndrome trial. And so he's doing several studies trying to sort of look at the different components of placebo effects. And there's one trial I want to tell you about, again in irritable bowel syndrome, and again looking at placebo acupuncture. So I've got a graph here. This is 3 different groups of patients, and it's showing you what percentage of the patients in each group said that they had adequate relief after the trial. And the group on the left, that was the control group. They were on the waiting list. They had no treatment. 28% of them said they had adequate relief. So either they would have just felt better over time anyway, or just something about being in a trial made them feel better. The middle group, they got the placebo acupuncture from a practitioner who was cold but polite, who did the thing with the needles but didn't really interact or say much to them. 44% of those said that they had adequate relief. So there was a placebo effect there. Something about that ritual with the needles was easing their symptoms. And then the third group on the right, they had exactly the same treatment with the needles, but this time the practitioner was warm and empathic, asked them lots of personal questions, listened to the answers, had long silences, touched them on the arm. And in this group, 62% had adequate relief from their symptoms. And that is as high as you would get from any trial of any drug for irritable bowel syndrome. There was another trial, a smaller trial, that looked at acid reflux disease. This trial compared a homeopathic remedy with placebo and found no significant difference between the two. But the trial also they had 4 groups, so they also looked at the difference between a standard consultation with a doctor, a sort of short 18-minute consultation, and a long personalised consultation, around 44 minutes, which is more like the sort of consultation you would get with a homeopathic therapist. The group that had the standard consultation, 17% of them said that their symptoms were at least halved afterwards. In the long consultation group, that proportion jumped up to 75%. So we need more studies on this, but I think what they're starting to show is that regardless of what treatment you're prescribed, how that care is delivered can have surprisingly large effects on patient outcomes. And I think that's really troubling when a lot of our healthcare systems are going the other way and focusing just purely on the physical drugs and interventions and cutting back on things like nursing staff and consultation times. Another approach to this is to use this understanding of the role of the brain and the mind in these symptoms to develop completely new kinds of evidence-based therapies. So this is a scene from a 3-dimensional virtual reality game called Snow World. I got to try it. So you have the sort of virtual reality goggles and you feel as if you're inside this world. It's a virtual ice canyon that you're floating through it. You can look up and down, spin around. There are these characters, penguins, snowmen that throw snowballs at you. You can throw snowballs back. It's really fun. But it was developed for a very serious purpose, which was to help patients with severe burns. These patients have to undergo wound care sessions where dead tissue is scrubbed out of their burns. And then later on, they have to undergo physiotherapy as their wounds are healing to stretch and literally tear apart the scar tissue as it forms to ensure that they still have range of motion as they heal. This is generally considered to be some of the worst pain in medicine. Patients often say it's worse than being burned in the first place. And even with the highest safe doses of painkillers, they're still often in agonizing pain during these wound care sessions. So researchers in Seattle developed this game based on the principle that the brain only has a certain capacity for conscious attention. So the idea was that if that attention is being grabbed by something really compelling, like a virtual ice canyon, there is going to be less attention left over for experiencing pain. And they've done several trials on patients, including veterans of Iraq and Afghanistan who've been burned in explosions, and shown that it works. If they play Snow World while they're going through these wound care sessions, that reduces their pain by up to 50%, in addition to the pain relief that they get from the drugs. And immersion, this illusion of being physically present in that virtual world, seems to be really key to the pain relief. This works much better than other forms of distraction like music or normal video games, and it seems to be that sort of convincing the brain that you're in this distant, safe place that seems to be key to how it works. So all of that so far is talking about symptoms, how we feel, but psychological cues also can have a dramatic effect on our physiology. So to talk about that, I would like, first of all, to invite you to look at these pieces of lemon, and imagine picking up that piece in the front there and take a big bite. Sink your teeth into it and imagine swallowing that juice. If you have a good imagination, and importantly, if you've eaten lemons before, you might start to feel a sort of tingling sensation at the back of your mouth. And that is your salivary glands switching on. Your body has learned the appropriate physiological response to lemon juice. It's producing extra saliva in preparation for that acidic juice. And there are, lots of examples where we all know from experience that our thoughts and beliefs can affect physiology. So with the lemons, I couldn't have said to you, oh, just switch your salivary glands on, please. It's not under conscious control, but you can use the visualization, the image, to make that happen. And other examples where sort of thoughts, beliefs can trigger physiological changes that we wouldn't think of as being under conscious control are things like panic attacks, phobias, sexual arousal, tears. There are lots of examples. And in general, aspects of our physiology, from heart rate to digestion, are ultimately controlled by the brain. It usually happens automatically. We're not aware of it. The brain is responding to physical signals to respond to changes in the environment. We can't will these changes to happen usually. It'd be quite dangerous if we could suddenly tell our heart to beat at 120 beats per minute. But still, our psychological perception, things in our environment that we see, hear, smell, things that we think and believe, these can have profound effects on these processes. And we've evolved this way. It's to help our bodies to stay one step ahead of threats and challenges in the environment. Rather than waiting for things to physically hit us, we can use our perceptions of the environment, what's likely to be the next thing that we're facing. And so an obvious example of that is the fight or flight response. When we're afraid or stressed, there are a range of quite dramatic physical changes happen. Your heart beats faster, your blood pressure rises, your pupils dilate, blood is diverted from your gut to your limbs and brain so that you can think and move. Fight or flight response also triggers a branch of the immune system called inflammation, which is the body's first line of defense against infection or injury. And all of these changes are important in an emergency. They could help us to survive a particular threat. But if they're switched on long term, if we're chronically stressed, as we hear all the time, they can be very damaging and increase wear and tear on the body. Chronic stress increases the risk of heart disease, of gut problems. Chronically high inflammation exacerbates autoimmune conditions. For example, it disrupts wound healing. It makes us more susceptible to infections, from the common cold to HIV. It's implicated in cancer and even in the rate at which our cells age. And in my book, I look at different evidence-based ways to either reduce stress or change how we respond to stress, to have a more beneficial physiological effect on the body long term. But for today's talk, I just want to give you an example of how reducing fear and stress can have a very important immediate effects on our health. And that's during invasive medical procedures. So there are a lot of procedures today, things like keyhole surgery, biopsies, tumor destruction, that take place where we are conscious, we're aware of the whole procedure. We're given local anesthetics and sedatives, But imagine being that patient there. Even with the drugs, these procedures can still be very painful and scary. And so a research team at Harvard again decided to take a different approach. Rather than just giving higher and higher levels of sedative drugs, which is what normally happens, they took a more psychological approach. And they've done several trials and hundreds of patients undergoing these types of procedures. And this is a graph from one of those studies. So they asked patients to rate their pain and anxiety every 15 minutes during the procedure. And so this is showing you the pain score on the left, anxiety on the right, over time through the procedures. And the top line, those black blobs, that's the control group. This was standard care, which is sedative drugs on demand. All three groups got sedative drugs on demand. And you can see that pain and anxiety basically just rise through the procedure. The longer it goes on, the worse those patients feel. The middle group, that dashed line, the medical staff changed how they communicated with the patients. So they tried to remove warnings of how much things were about to hurt, for example. They also responded to patients' requests more swiftly and tried to make the patients feel more in control. And that made a difference. The pain and anxiety scores were significantly lower. It jumps about a bit, but in general, it's staying roughly flat. The third group got both of those things, but in addition, they were encouraged to use visualization techniques to help them to relax. So this is things like closing your eyes and imagining yourself somewhere that you'd rather be, whether that's a beach somewhere or your sofa at home. And again, that helped even more. When they did this as well, the pain and anxiety actually went down. So the longer that the procedure went on, the more comfortable those patients felt. The procedures also went more smoothly. They were over more quickly. You can see that the line is shorter. Those patients required only half the amount of sedative drugs compared to the control group. And importantly, they suffered significantly fewer complications. So this is quite serious things like prolonged lack of oxygen, dangerously low or high blood pressure, post-operative bleeding. And so I wanted to give you that example because it shows that in this case, caring for the patient's mental state rather than just giving higher and higher levels of drugs didn't just make the procedure more pleasant for those patients, although I think that kind of on its own would probably be a good enough reason to do it. It actually changed their physiology in a way that altered the physical outcomes of that surgery. And I just want to finish on an area of research that when I was doing the book, it was, for me, the most surprising exciting line of research in a way that I came across. And this is looking at how psychological cues can influence the front line of the body's fight against disease, the immune system. And this is a class of responses called learned responses. And it all started with an experiment that went wrong. A psychologist called Robert Ader in the 1970s was interested in a phenomenon called learned taste aversion, which you might have experienced. This is where if we eat a food and then we get sick, so prawns, for example, if you have that food again, even if you liked it to start with, it makes you feel sick again. You don't really fancy eating it. And there's an important survival value to that response, is to discourage us from eating food that's poisoned us in the past. Ada was interested in how long that learned association between the taste of that food and feeling ill lasts. So he did an experiment on rats where he gave them water sweetened with saccharin. This is normally a favourite treat for the rats. They drink more of that than normal water. But in this experiment, he paired it with a drug called cytoxan, which made them feel sick. And after a few pairings, as he expected, the rats refused to drink the water, even when he gave it to them on its own. So to see how long that memory would last, he force-fed the sweetened water on its own to them using an eyedropper. But they didn't forget the association. Instead, what happened is one by one, the animals fell ill and they died. It turned out that cytoxan, as well as making the animals feel sick, is an immunosuppressant. It suppressed their immune systems. And they hadn't had anywhere near enough of the drug in this experiment to be fatal. But what Ada worked out had happened was that as well as learning to associate the sweet taste with feeling sick, they had also learned the immune response to the drug. And once they'd learned that association, the sweet taste on its own suppressed their immune systems enough that they succumbed to infections and they died. So in this case, a neutral psychological cue, the sweet taste, had been enough to kill them. Scientists have also shown the reverse. You can use these learned associations to boost the immune system. There was some work done in guinea pigs, for example, where researchers heated their skin at the same time as giving them an injection that triggered a particular immune response. And then heating their skin on its own helped those animals to survive what would normally be a fatal injection of cholera. These are examples of Pavlovian conditioning. So you've probably heard of the Russian physiologist Ivan Pavlov, who trained dogs to associate being fed with a neutral cue like a sound or a light, until just the sound or the light on its own would cause them to salivate. You didn't need the meat to be there anymore. What Ada showed was that these conditioned responses don't just influence salivation and digestion, they're actually guiding the immune system as well. And at the time when he did this research, this was seen as pretty much pseudoscience. This was the 1970s. Scientists were convinced that the brain and the immune system are completely independent. They don't talk to each other. They thought that the immune system was responding autonomously to physical signals like injury and infection without any help from the brain. We now know, however, that there is extensive two-way communication between the brain and the immune system happening all of the time, and this is happening through nerves and through chemical messengers. And again, this is really important for our survival. It's helping our immune systems to stay one step ahead of challenges that we may be about to face. So I mentioned the example before of the fight or flight response triggering inflammation. So that we're ready for the infection or injury that might occur in a dangerous situation. Learned associations seem to do the same thing, but in a more specific way. So to take that example with the prawns, if you eat prawns and then you get sick with salmonella, it may be that the next time you eat prawns, you haven't just learned to feel sick. Your body may have learnt the immune response that it needed the last time you ate prawns, so it is prepared for that potential infection before you even take your first bite. And we need more research in this area. It's not an area that a lot of immunologists are looking at, but it may be that our immune system is actually responding all the time to these types of psychological cues to try and stay one step ahead of what's going on in the environment. Ada wondered whether he could use these learned responses to treat disease. And then he got a call about this girl on the left. She's called Marette, and she lived in Minnesota. And in 1983, when she was 11, she was diagnosed with the autoimmune disease lupus. It was a very severe form of the condition. She suffered from kidney damage, seizures, high blood pressure, pneumonia, severe bleeding. When she was 13, her heart started to fail. Her life was in danger, and her doctors wanted to give her Cytoxan, the same immunosuppressant drug that Ada had used on his rats. But her mother, Marette's mother, was really worried about this. Cytoxan is a really toxic drug. It has a long list of side effects. Its use in humans at the time was experimental. She was worried that the drug was going to be just as dangerous for her daughter as the lupus was. But she was a psychologist, and she had read about Ada's work. So together with one of Marette's doctors, they contacted him and said, well, could we use these learned responses on Marette to try to reduce the amount of drug that she needs? So he agreed to try. He said that it wouldn't really work to use the sweet taste saccharin on a person because we eat sweet things all the time. We'd be unlikely to form any particular association with that sweet taste. So instead they came up with this mixture, cod liver oil and rose perfume. And they were looking for something that would be really distinctive, unique, unforgettable for Marette. So every month for 3 months she had her dose of Cytoxan. She ate a spoonful of cod liver oil and they wafted rose perfume around the room. After that, she got the cod liver oil and the rose every month, but the drug only every 3rd month. So that by the end of the year, she'd only had 6 doses of the drug rather than 12, and they were hoping that that cod liver oil and rose that would trigger that association and help to suppress her immune system, even without the extra drug. And she responded really well. She responded just as the doctors hoped that she would do to the full drug dose. She got through that crisis in her condition. She was able to revert to a milder medication, and she went on to college. Now, that is just a single case. We can't say for sure that it was the conditioning. the learned responses, maybe she would have responded well anyway. But that research has continued, and one of the main researchers looking at learned immune responses now is this man, Manfred Schedlowski, working in Germany. He has also taught rats to associate a sweet taste with immunosuppressant drugs. And he's shown that once they've learned that association, the sweet taste on its own can delay the rejection of transplanted hearts in those animals, which I think is really incredible that a taste could have that effect. And he's also working on humans, and his version of the cod liver oil and rose perfume is this green drink. It's a mixture of strawberry milk, lavender oil, and green food colouring. I've tried it. It is disgusting, but it's like nothing else you've ever tasted. It looks green, but because of the lavender, when you drink it, it tastes purple, and it's bitter, it's oily, it's milky, it's sweet, it turns your stomach, so you're not going to forget it once you've tried this drink. And he's shown that if you drink this drink along with taking an immunosuppressant drug, then after a few pairings, the drink on its own will suppress your immune system in just the same way that the drug did. And it's like the lemons example I gave you earlier. It doesn't matter, unlike the placebo responses I talked about at the beginning, it doesn't matter that you know that there's no drug in it. Just like with the lemons, you knew that that wasn't a real lemon, but it can still trigger the response. This is just a learned response that the body triggers automatically. And Schedlowski has shown that this works in healthy volunteers, in people with dust mite allergy, and he's now doing studies on kidney transplant patients to see if drinking this drink alongside their medication can then help to reduce the dose of medication that they need in order to reduce side effects and the toxicity of those drugs. And this is particularly important for kidney transplant patients because the drugs that they have to take to suppress their immune systems to prevent rejection of the organ is actually directly toxic to the kidney, the very organ that you're trying to save. As many kidney transplant patients lose their kidneys from the toxicity of the drug as lose it from immune rejection. So anything that could reduce the drug dose could be really important in prolonging the life of those organs. But in general, the hope is that an approach like this could help to reduce drug doses and therefore side effects, toxicity, drug tolerance, addiction, cost in a range of autoimmune conditions, allergies, even cancer. Schedlowski has shown that you can condition the responses to some cancer chemotherapy drugs as well. These conditioned or learned responses are also at play in conditions like pain and Parkinson's that I was talking about at the beginning. When we take placebos for these conditions, there seems to be a combination of the conscious expectation that's having an effect, but also these learned responses. If you've taken paracetamol lots of times in the past, your body has learned the response to that paracetamol and is probably going to trigger it again if you take a placebo. So it's the expectation and the learning that are working together, and combining placebos with learning protocols, it seems that you can actually make placebo responses much more consistent and larger. So that's been shown in pain, but also in Parkinson's. There was a study recently showing that if you give Parkinson's patients a placebo, not everybody has a response to that, and the response is smaller than you would get with the drug. After they had given, if they gave a drug 4 or 5 times in a row, like each day, daily, and then the next day gave a placebo, then the response overall to the placebo was just as large as the response to the drug. So it may be that by combining these two things, we can actually make placebo responses much more consistent and larger. And so one approach that's being talked about now to reduce drug doses is that you might get a blister pack of pills, for example, and you know that some of them are drugs and some of them are placebos, but you don't know which. And so you get the same clinical benefit, but for a lower drug dose. And so, I wanted to talk about that example because I think, again, it shows that this isn't a case of choosing either a physical approach to treatment or a psychological one. I think what's really important is that we learn how to use both of those things together in an intelligent way. So just to conclude, in writing the book, my conclusion was that the influence of the mind on the body is not mysterious or magical. It's just biology, a matter of survival. The mind influences the body through neurotransmitters and nerves. We have evolved so that psychological cues are thoughts and beliefs about our environment. guide both the symptoms we experience and our physiology to help our bodies to stay one step ahead of challenges in the environment. And that means that the mind is not a miracle cure. There are clear limits to what it can do. It can only affect aspects of our physiology that are controlled by the brain, for example. Our thoughts aren't going to allow us to create chemicals that the body isn't capable of making. The mind can only work within normal physiological limits of the body. It can't magically save us if the body is overwhelmed by infection or cancer, for example. And we can't generally will changes to happen. We can't wish pain away or tell our immune system to respond in a certain way. There's no evidence that just general positive thinking is going to be particularly helpful. But I think if we can understand exactly how and why the mind affects the body, then we don't have to resort to magical thinking about the mind-body connection. We can develop evidence-based therapies that take advantage of these processes, whether that's making people feel cared for, immersing them in virtual reality, or taking advantage of senses such as taste and smell. And I think that would help to lead to an approach to medicine where we treat patients not just as physical bodies, but as human beings. Thank you.
Thank you so much, Jo. I thought that was really fascinating, and I wish we had more hours to listen to you. Maybe you can record your book for those that are driving long distances to...
There is an audio version.
Oh, there is. Great. There's an audio version of the book, but you can still buy the book. Don't forget that as well. We have half an hour for questions for Jo, and I can imagine you have all very urgent questions to ask. And since we only have half an hour, we have to be selective, but who would like to pose the first question? That is always very scary, but think about what she's been telling us. There's nothing to be scared about. Who has the first question? Okay, and now Jack is going to run up, I think. Yeah? This is going to be good for your condition.
Good exercise.
Is it, yeah, are you? Oh, this is a very good audience to do this. I already see that.
Do we have two microphones?
I think we have two microphones, but I only see one person running. We have one microphone? Oh, we only have, okay, it's going to be, okay. Okay, you go.
Thank you.
My question regards mental states more. So since there's so much evidence nowadays on chemical imbalances in, for example, psychosis, is it possible to use any placebo effect for people with psychosis?
In the book, I looked mostly at what we might think of as more physical conditions rather than psychiatric conditions, just because I had to limit it somehow. And so I think we kind of instinctively would accept that the mind plays a strong role in psychiatric conditions, but perhaps there's more resistance to the idea of it affecting the body. So I didn't look at that specifically for the book, but I think that stress and anxiety and ways of reducing those, I mean, this whole separation between the mind and the body doesn't really, I mean, my conclusion at the end was that it doesn't really exist. It's all part of the same thing. So just even dividing psychiatric conditions and physical ones doesn't really make sense. So in general, I would just say that yes, anything that can reduce stress and anxiety and increase positive expectation, certainly in depression, I didn't look specifically at psychosis, can have an effect, but I don't know enough to answer your question more specifically.
Hearing your arguments, it seems to me that throughout history, all people who were involved in medicine, by whatever means, must have been aware of this effect. Have you samples of that?
I think historically, sort of before the advent of modern medicine, I guess, then physicians were very aware of the importance of the patient and their own beliefs and attitudes, and we have a lot of writings to that effect, and in effect the placebo effect was largely what they were working with. I think that, and even now, I think a lot of primary care physicians probably know very well that this is important, but certainly in the UK they're working within a system that makes it very difficult for them to really harness that. You know, GP appointments are 10 minutes each, so there's not a great deal that you can do. I think there's lots of reasons why the effect of the mind has kind of sort of been written out of history in a way when it comes to medicine. Some of it is just a sort of the modern scientific worldview, and some people trace it all the way back to Descartes, the sort of split between the mind and the body, and this idea that physical, objective, measurable things are kind of more real and more suitable for scientific study than kind of the subjective thoughts and beliefs of the mind. And although that's not a view that neuroscientists would really say was valid today, I think internally a lot of scientists still have that kind of, even if they don't acknowledge it explicitly, there's this implicit feeling that anything to do with the mind is a bit suspect and not really real. I think there's also just the way that we do clinical trials. So in placebo-controlled trials, it's really important that we have them to separate out whether drugs are working or whether it's the placebo effect. But at the same time, in doing that, we are, in effect, throwing out everything about a treatment that isn't the direct biochemical effect of the drug. Everything to do with how the care is delivered, the length of the consultation, the attitude of the practitioner, the hopes and beliefs of the patient, their previous experiences, everything is thrown out pretty much as worthless. We don't measure or value that, and therefore we don't have any evidence-based way to incorporate that back into medicine. And then also there's who's paying for the research as well. Like the majority of clinical trials are carried out by drug companies, and you know, quite reasonably they're doing their trials into drugs, so we don't have a lot of research looking at these aspects. So I've gone slightly off topic from your question, but I think it's something that people throughout history, doctors have always known, but these sort of different things have kind of combined in more recent times to have them ignored or sort of denied by a lot of scientists. Yeah.
Okay. Well, first of all, thank you very much. I really like it.
Thank you.
I have a question for you because I've been reading research from immunologist Mr. Dabar. Maybe you know from Stanford, I think he is. Dabar. No? No. Okay.
Oh, with an DH. Yes, sorry,
Dabar,
yes.
Right?
Yeah.
Yeah. And he was writing about if people had to undergo surgery, if they prior to that surgery experienced acute stress, that had a positive effect on the recovery. And how do you relate that to that, for example, the snow world with burning bones?
Yeah, his work's really interesting. So we hear a lot about chronic stress and how that suppresses the immune system and how that's generally bad. And he's looking at acute effects of stress, so sort of short bursts of sort of minutes to hours, I guess, and showing that can boost aspects of the immune system, which kind of makes sense because sort of in the moment, if you're stressed, you're likely to need that boosted immune system. So yeah, it's absolutely, stress isn't, we tend to think of stress as being all bad, but it's that chronic, unrelenting stress, particularly when people are feeling out of control, like they don't have the resources to cope with what's being thrown at them. That's the kind of debilitating stress. And actually, acute bursts of stress can be very helpful for us. And also, there's a distinction that psychologists make between threat and challenge, which I've heard described as if you imagine a skier sort of she's skiing and she comes to the sort of top of a black run, and depending on whether she's a beginner skier or an experienced skier, she could either feel kind of terror, it's a threat, or exhilaration, it's a challenge, depending on whether you feel you have the resources to cope with the situation and whether you're focused on the possible benefits or the possible downsides. And this kind of has an evolutionary explanation to it as well. So I'm going to try and remember to get the details right now. But if you imagine that you are in a situation that you think you're going to lose, so you're in a fight and you think you're going to lose, or you are being chased by a predator and you're going to get eaten, essentially the I've got to try and get it the right way around now. The hormone changes are different. They act in a way that the heart is beating faster, but blood flow is reduced. The blood vessels are constricting, and this is to reduce blood loss when you're injured. And that's actually quite a damaging response, particularly long term. Whereas in a sort of challenge environment, actually there's dilation of the blood vessels, the heart's beating faster, but blood is pumping much more efficiently around the brain and the body, oxygenating the brain, oxygenating the body, and that's a more helpful response. There's less pressure on the heart, for example, and that's enabling you to respond. You know, you can run faster, you can think faster, you can respond better in that circumstance. So depending on whether you kind of think you're going to win or lose, for example, the way your body reacts is very different. And there was some really interesting research looking at how you can switch yourself from one to another. And there was a whole series of studies where they made people sit an exam, a sort of fake exam in the lab. It was a particular exam that graduate students have to sit in the US. And they would say to them, if you're feeling nervous, if you notice sort of physical signs of anxiety, you know, sweaty palms, or if your heart's beating, just remember that's a really good sign. That's really going to help you. That is going to pump oxygenated blood to your brain. It means you're going to, you know, it'll really help your performance in this exam. And it was randomized, and they had that, and then they had a placebo thing they told them, which was just try and ignore the source of your stress, and then they had a no treatment group. And the ones who were just told that very simple thing, it changed their response from a threat response to a challenge response physiologically, and they also scored higher in that mock exam, and they also scored higher in the real exam, which they sat 3 months later. So it just shows you that I've really simplified it in the talk, but you know, we have lots of different ways of responding to stressful situations. You know, some are more positive and some are harmful, but that would be my top tip if you've got something like public speaking to do. And you feel yourself getting nervous, just think it's okay, it's sending oxygenated blood to my brain.
I had a question about the medicine world, because placebo is, it's not really medicine, of course, but very good for the environment, nature, and for our future. But how will the placebo develop when the medicine world is so big and aggressive with the whole money issue and just that? Thank you.
Yeah, I think it's kind of a bad news, good news thing. On the one hand, it's very difficult. I mean, there's very little funding for this kind of research. There's a few groups that are doing it, but they're really struggling for support. And you know, the pharmaceutical industry is obviously hugely powerful lobbying groups, and they're sort of not going to give up their kind of hold on this sort of drug-focused approach that we have to medicine very easily. And so unless we find alternative funding streams, one alternative actually might be the gaming industry. If virtual reality, there are now, with the headsets becoming cheaper, they're becoming much more available. There are more and more companies developing different virtual worlds aimed at psychiatric disorders and also chronic pain as well as acute pain. So who knows, maybe we'll see some of those companies, you know, developing health divisions and starting to carry out their own clinical trials. But generally, yeah, it's very hard to see how that is going to change. On the other hand, developments in neuroscience, I think, are really helping, because in a lot of these areas, from mindfulness to placebo research, neuroscientists are doing brain scanning studies that are actually showing changes in the activity and sometimes the structure of the brain when we respond to a placebo, when we do mindfulness training. And that is really helping scientists to take this kind of work seriously, because now we can actually measure and image the changes that are happening. So it's turning from being a kind of vague, subjective field into something where you can prove that there's really something physical going on. And so I think that's really going to help all of this research to move forward.
In your book, discriminate, eh? If people on that side, please raise your hands, eh? Yeah, you just have to run.
Okay, so in your book you mentioned the amber necklace, you know, the teething necklace for infants. I wanted to understand, how does it work on Earth? another person, especially
right,
on
yeah.
a baby. And because I also have 2 friends who have used it on their babies, and they're convinced that it works. So I would like to understand a bit more.
Yeah, so this is something I mentioned in the introduction to the book. So I was talking, because one of the ways I got interested in this... I'll just keep talking.
Come on, jump.
I got interested in this whole topic because it used to be that all my friends were scientists and science journalists, and they all have the same very sort of rational, black and white scientific worldview, and then suddenly you have kids and you have a whole new set of friends who don't necessarily share that worldview. And suddenly I did have friends who were raving about homeopathy and using amber teething necklaces. I don't know if you know these, so it's just a little necklace made of amber stones, and I think that supposedly there's some chemical in the amber that leaches into the baby and eases their pain. I mean, it's not something, you know, even if that was true, I don't think I would want to put that on my baby. But anyway, they swear by these things. And these are intelligent, educated women. It didn't seem to me to make sense that you can just say, oh, they're just ignorant and stupid, because they're not. And so it did make me very interested to look into this whole area and say, well, what is science missing here? I don't think the answer is just to dismiss these alternative treatments, because so many people clearly have this personal experience that it works. So that's not an answer to your question. That's just introducing why I was talking about amber teething bracelets. But yeah, so there is definitely a category of placebo effects where they're not working on the person themselves. So amber teething bracelets given to babies. I also talk about an autism treatment, so the hormone secretin that was given a few years ago in the US, that was being given to kids with autism, and parents were absolutely raving about it. It seemed to be doing wonders for their kids, and all these hundreds of families were trying it. All the companies ran out of this gut hormone, and when they did clinical trials, they found out that it was no better than placebo. But what one of the researchers in that trial told me, that he didn't put in his paper, but he was really struck by how much better both groups got. They both significantly improved. There are also cases of placebo effects on animals, for example. So you've got supposedly placebo effects in babies and children or animals who presumably don't have any particular belief in that placebo. And it does seem to be that just we are able to respond to very subliminal cues, non-verbal cues in the person who's giving us treatment. So probably what's happening is that just the belief that the parent has is reducing their stress and anxiety, and is changing the way that they are responding to the baby or the child or the animal, that in turn is feeding through into a placebo effect. And we know that this does work in adults as well. So there was one study where the patients thought that they were receiving a painkiller. They were all receiving a placebo. But what was different between the two groups was what the doctors believed. Some of the doctors thought they were giving a placebo. Some of the doctors thought they were giving a proper painkiller. All of the doctors were told to tell the patient it was a painkiller. So what they were saying to the patients didn't change, but the doctor's sort of belief was different. And that had an effect. There was a significant placebo effect when the doctor thought it was a painkiller. They had significantly more pain relief than the ones where the doctor thought it wasn't going to work. There have been other studies looking at subliminal cues where you can flash up like happy or sad faces, but too fast for people to actually realize consciously that they've seen it. That can influence placebo responses. So I think it's showing you that it can be very subtle. It's not always as explicit as this is going to reduce your pain. We're taking in all sorts of cues from our environment and the way that we're being treated that can speak to us unconsciously as well to trigger these changes.
Hi, very interesting talk, which of course raises all sorts of questions. And I was particularly intrigued because you say, okay, this placebo effect can work for immune responses and pain responses. And there I can easily see a connection between the body's normal responses and you've enhanced them or maybe confused them or directed them in some way. But I was very intrigued by then the suggestion that it might work for chemotherapy. because chemotherapy, at least to my understanding, I'm not a cancer person, but is effectively a poison that you hope kills the cancer cells quicker than the regular cells. And then that's not there in a placebo thing. So that chemical is no longer there. And as you said, it's not making the body produce things that it shouldn't do. Does that mean potentially at least we are misunderstanding how the chemotherapy actually functions?
No, very good question. It obviously depends on the chemotherapy drug, and a lot of cancer chemotherapy drugs are actually modulating the immune system. So it's just another extension of... So if something is acting purely as a poison, then no, you wouldn't expect to have learned responses. So it has to be... They've done studies in rats, sort of cutting through different nerves and shown that this communication, the learned response, is completely dependent on the autonomic nervous system. So that's what's... So you will only learn a response if the effect of that drug is somehow going through the brain and acting through the autonomic nervous system. And some chemotherapy drugs do. A lot of them don't. So sorry, I didn't mean to imply all chemotherapy drugs. But it raises another question, which is, well, what about the side effects? Like, wouldn't you learn... I talked about reducing side effects. Wouldn't you learn the side effects to these drugs as well? And we know that happens, for example, with chemotherapy. People learn to associate feeling sick with those drugs that they're receiving, and it's quite a well-known phenomenon that people will start feeling sick as soon as they get to the hospital, even before they've had their dose of the drug. And so you could use this, there are ways that you could try and use this understanding to reduce that to start off with. So, for example, it's been suggested that if you were going to have chemotherapy, if you visited the hospital a few times before, then when you go and have the chemotherapy, you're less likely to form that association. So you will still get the nausea from the drug, but you won't get the extra learned nausea. But also in terms of the side effects, so something like nausea, where the brain does play a role, you probably would learn that as well. So if you were having the green drink, it wouldn't really help with that. But where it is going to be helpful is things like direct toxicity. So as you were suggesting, if you've got a direct toxicity of the drug on a cell, the brain's not playing a role in that, so you wouldn't learn the response. So with these kidney drugs, for example, it's just the drug is directly poisoning the cell of your kidney, so there reducing the drug dose is likely to be helpful. But it's something that we need a lot more research on. Where they're getting to now is trying to pin down, well, first of all, exactly what sorts of regimes are the most effective. You know, how many times do you need to pair them? What's the best time interval between? How can we stop that learned association from being forgotten? And then also exactly what things can be conditioned and which things can't be conditioned.
Thank you for the presentation. I've just graduated as a pharmacist, and so you are facing placebo and nocebo effects with patients, and you can see that, for example, when they are taking a very low doses of a drug and they are happy with the effects. So you won't argue with them and saying that, well, in clinical trials it shouldn't work. But I was wondering, because like they speak more and more in healthcare about shared decision making. So you try to make the patient aware and upward about their decision about the treatment, etc. So it could have also effect like, related to the positive or negative effect of the mind. And I was wondering if you have already looked or thought about the ethical perspective of the caregiver. They have to, if they decided, for example, to give a placebo instead of a normal drug.
No, it's a really interesting question. I think with placebo, certainly, although it happens a lot, the general view is that giving a patient a placebo and not telling them is not ethical, but there are kind of ways around that, I suppose, where you can, when doctors prescribe antibiotics for viral infections or iron tablets or whatever. But I think what's interesting about the honest placebos is that you can tell people and there will still be an effect. And in the studies where they just said, take a placebo, like that, the sort of chart that I showed you with the migraine headaches, it seemed that there is a significant effect, but obviously it works even better if they think it's a drug. But with some of the other trials, like the irritable bowel syndrome and the chronic low back pain, so these more chronic conditions, the way that the researchers did it was they gave people like a half-hour seminar on pain and how pain works and the role of the brain and why placebos may help people. So a bit similar to this lecture that I've given. And in those people they had, so I think that was a really good way of including patients. It's not just sort of giving them a pill and pretending it's something else. It's saying, okay, we know that your brain plays a really big role in pain, and we think that this could be a way of kind of triggering your brain to ease off on that pain. So you're including the patients in it. And so I wonder actually whether you still need to take the pill at all in a way. It might have just have been the education that did it. They would probably need to do more trials to work that out. But I think we don't have to think of harnessing placebos as fooling people or lying to them about what we're giving them. I think it's just a way that we can all understand better how our brains and bodies work and take advantage for that for ourselves, whether we're doing it in our own lives or whether doctors are helping us to do it. I'd see it more as a sort of empowering thing, that the more information that we have about that is the better, really.
Hi. I would like to skip back to your what you just mentioned about it being very difficult to finance research into placebo use. Well, I would think that health insurance companies would be very interested. I mean, there's a constant battle of making health care more and more affordable, keeping the cost as low as possible. So I think a placebo would always be cheaper than the real thing. So maybe that would be something for them to be interested in more finances.
Yeah, it's an interesting one. I mean, I think one obstacle is that you need to have the evidence base. So you do need the sort of the funding for the studies, I think, before the insurance companies can really go for something. I was talking to David Spiegel at Stanford, who is a hypnosis researcher, about this, and his take on it was that actually it benefits insurance companies when healthcare costs are high, because the higher the cost, the bigger their cut, if you like, that the less we spend on healthcare, actually overall the less profit they make. And I'm not an economist and I don't know whether that argument is valid or not, but that might be a factor. And also I think there's a kind of, for some of these therapies you need to completely rethink the sort of payment streams for things, how you bill for them, for example. And I think there's kind of a barrier to sort of taking on things that don't fit the conventional structures. So I was at a chronic pain clinic in Knoxville, Tennessee recently, where, I mean, they have huge problems with opioid addiction over there, and they're trialing virtual reality for chronic pain. So they're doing some trials, but the psychologist there who was doing it, he's paying for it himself. He says, I don't have a boat, this is my hobby, this is what I'm doing. But he says he actively discourages the physicians in that clinic from actually referring any patients for virtual reality because he can't bill for it. There is no category in which you can have a psychological therapy as you can bill for training where you're teaching skills like CBT, or you can bill for a physical drug or interventional surgery, but he just can't bill for putting somebody in virtual reality for however long. And so it is a bit of a catch-22 situation that when something is a bit outside of the box, and you need a lot of kind of sort of bureaucratic things to change, that can be hard to do sometimes.
Hi, thank you very much for your presentation, very interesting.
Sorry, can you just...
Yeah.
Oh, sorry, I see.
I would like to ask one question, and it's the time effect. Because you said that even if you know that it's placebo, you will still have a positive effect. But for how long that would last? And could you actually design it in such a way that the time effect will be reduced?
The time effect would be reduced?
Yeah. Do you understand what I mean?
Yeah, would you not want the time effect to be
So if you know
longer?
you're taking placebo and you take it for many times, for how long that effect will last, and if the time effect will have an influence. So the longer you take it, the less influence placebo has.
Right, okay. I mean, it varies a lot. I mean, so there are some times when Parkinson's patients take placebo, for example, it might last for about half an hour and then tail off, but that's about what you would see if they take a hit of drug, and it also tails off. And with sort of placebo painkillers in the lab as well, you might see a sort of short-lived effect, but equally that's the same that you see with most drugs that you take. It's quite short-lived. You have to keep taking them. But then there are other trials where they've seen quite long-term effects over months or years. So I think it really depends. I think when you see the longer-term effects, it's probably to do with when people's attitudes towards their condition has changed. Perhaps you've just, whether it's reducing stress or anxiety levels, or often you get interactions with people's behavior as well, that if they take a placebo, often people with chronic pain, for example, end up in quite a negative spiral where they don't go out and do certain activities because they're afraid that it's going to hurt them, because of their pain. So then they end up staying in, which first of all has a bad effect on their mood because they've got nothing to distract them from the pain. The pain seems worse. It can contribute to anxiety and depression, and it can also make them deteriorate physically as well because they're not being active. And so sometimes something like a placebo might help to break that cycle. So if giving somebody the expectation that they can actually go out and participate in activities might start something self-perpetuating that is then no longer reliant on the placebo. So I think it's complicated. You can have very tight, short-lived effects, just as you would see with taking a single drug dose, or you can have very sort of profound, long-lived effects that really change how somebody thinks about their condition. So it's complicated.
I have a question about a case. Someone, a female person with hyperacusis. So certain sounds are really very painful, like eating, hearing, being at a dish with people eating with spoon and fork and knife on plates, but also traffic noise, for instance. This came into existence when she was in puberty, and by paying very much attention to this kind of sounds. Would you have a suggestion how she could get rid of this?
I don't think I have a quick fix for that, but in general, I think stress and anxiety and focusing on symptoms like that and worrying about them are going to amplify them and make them worse. So anything that you can do to reduce that psychological component isn't necessarily going to cure the problem. It's not going to make the condition completely go away. But I think there is a range of how bad those symptoms can be, and we can amplify it by worrying about and focusing on symptoms, and we can minimize it by changing the way that we think about those symptoms. So I don't think there's a quick fix, but certainly mindfulness training, for example, has been shown to be quite, there's a lot of studies showing, I don't know about this specific condition, but in general it's quite effective in reducing the distress caused by chronic conditions, from multiple sclerosis to chronic fatigue syndrome to pain, anxiety, problems with sleep. So that's just something that can help somebody to sort of cope with those symptoms, and maybe in the long term might help to reduce them, but certainly would help to make them less distressing. Placebo, I don't know. I mean, in general, those kinds of symptoms, you do tend to see placebo effects, but I'm not aware of any trials specifically in that condition, so I wouldn't want to make any promises about that.
Final question.
Well, final question. First of all, thank you for a very engaging talk. You tackled very nicely all the mechanisms of how mind can potentially help curing the diseases and relieving the symptoms. But how about the vice versa? Have you tackled the topic of what mechanisms and what way can mind cause the diseases, and the other way around?
Yeah, it's a good question. I mean, I wanted to focus on the positive in the book because I felt it was a more positive message, and also I think we are kind of aware that stress is bad. We hear about the negative, and I wanted to turn it around. But absolutely, I think it's just two sides of the same coin, that your expectations, your beliefs, your thoughts, your stress levels, your perception of your environment can make things better or it can make things worse. I sort of see it as a sliding scale, if you like. So absolutely, everything that I talked about today has a flip side. You know, you've got the placebo effect where you can ease symptoms, but then you've got the nocebo effect where negative expectations can amplify symptoms or even create symptoms. In clinical trials, there's a significant proportion of people drop out of trials complaining that the side effects are too severe when they're in the placebo group. So we know that a lot of the side effects we get from medicines aren't actually down to those medicines at all. It's just down to our expectations. So I think that is an argument for not paying too much attention to those long lists of side effects that you see. And the same with stress. I mean, I talked about how chronic stress can increase the risk or exacerbate a whole range of chronic conditions. And so the research, we know that there are certain interventions that can reduce stress, and it's now a question of, and we know that it changes sort of physiological markers of that stress. I think the challenge now is going to be shown, well, does that actually reduce our risk of those conditions long term? There's a sort of plausible mechanism by which it might, and it would seem to make sense that it would, but we still need to show that. So all of this goes in both directions.
I think she deserves a very big applause.
Thank you so much.
That brings us to the end of this Tan's lezing. Don't forget to get a copy of the book. She will sign it, I think. I'll just make it up now. There is, of course, a drink, which is in the hall. Just follow the persons that are going there. Thank you also on behalf of the Studium Generale for joining us for this Tan's lecture. And don't forget also to to take the booklet for many of the other events that they are organizing. Enjoy the rest of your evening. Thank you very much.